So we did talk about cardio mechanics um, last week, and we went over how the heart really works. Um, if you remember, we said the heart has a twisting motion where the apex of the heart moves in a clockwise direction, and then the base of the heart moves in a counterclockwise direction. And then the heart also contracts from the base to the apex. It shortens, and in shortening, it thickens. Um, so when we talk about displacement, um, the classic definition for displacement is a parameter that defines the distance that a certain feature, such as a speckle or cardiac structure, has moved between two consecutive frames. Basically, displacement is distance with a direction. If there were no direction, then you'd have just said the distance. But because you have a direction, it becomes displacement. So displacement is a vector quantity, going back to some basic maths. Okay. So when the heart structure moves, it is displaced because it's not moving in a distance in an arbitrary fashion. It's actually moving in a certain direction, and that is why it's called displacement. And we measure displacement in centimeters. Okay. All right. Again, when we talk about velocity, these are all vector quantity. Okay. So the difference between, say, speed and velocity is speed with a direction. So it would be displacement per unit time, because remember, displacement is movement in a specific direction, or distance traveled in a specific direction. So when we talk about velocity, it is measured in this situation in centimeters per second, because it is displacement per unit time. So these are the different parameters that we use. These are the different parameters that we use when we describe the motion of the heart. Can you mute your phone, your speakers? Someone have a tremendous amount of noise. Okay. Okay. So all right. So again, can you guys mute? Can you mute your mic? Okay. All right. So we have said all of that because we strain, as we mentioned, is the change in length of the heart muscle, and it's a deformation, because if we're talking about longitudinal strain, then the muscle shortens. Um, uh, so it's a displacement. So it's a movement in a specific direction. So it's a vector quantity. Again, it's a fractional change in length of a myocardial segment. The Lagrangian strain is L minus L naught over L naught, and is expressed as a percentage, as we said before. It can be positive or negative. It's going to be, if you have a shortening, it's going to be negative. Lengthening is positive. Classic example when we talk about longitudinal strain, when the heart contracts from the base to the apex, it shortens. So that would be a negative number. So again, if you use the formula, you can see that the unit of strain um, well, it's a dimensionless because it's a length divided by a length, so there is no unit. But strain rate, which is the rate at which you get the strain, so it's going to be strain over time or strain over second. So it would be second to the minus one. Okay. We're going to concentrate mainly on strain, and as we have said before, if we're talking about longitudinal strain, then it's a local magnitude and direction, the shortening and lengthening of the myocardium. Okay, and there are certain conditions that we use global strain. Patients with any type of cancer who's going to get chemotherapy, common breast cancer, they're going to get certain type of chemotherapy. We use global strain to follow these patients because it's more accurate, and you can pick up a problem with the heart muscle much earlier than if you're looking at just ejection fraction. And we usually use global longitudinal strain. So what you do, you take a segment. So we divide the heart into different segments. So you take a segment and you can get the strain value for the different segments. Okay. Just remember the heart as a rotational movement, as we have said before. The apex moves clockwise and the base move counterclockwise. That's, okay. So again, in addition to the rotational movement, the apex moving clockwise, the base moving counterclockwise, the heart is shortening and lengthening. And then remember the fibers, we said the fibers sort of crisscross, so um, that allows the heart to move in the directions that we talk about. And you can, if you want to get real technical, you can you can you can you can you can express the rotational movement in degrees. All right, so you can talk about the twist angle. We're not going to get that technical, but you can apply certain mathematical formula to look at how well the heart is twisting then. So we don't routinely use this in clinical practice, but we can talk about twist angle, and we can look at torsion in more details. Tissue Doppler imaging. So when we started strain evaluation, the method that we used was tissue Doppler imaging. But as you recall, the tissue Doppler imaging is limited by the angle that the ultrasound beam makes with the moving structure. And because of that angle, it sometimes it's not accurate because you don't know if you're getting maximum velocity, yes or no. You have to just try and get the best velocity. In order to get maximum velocity, then you need to get the ultrasound beam as parallel to the moving structure as possible. That angle theta should be 0, okay? Because the cosine of 0 is 1, so you get maximum, you'll get the maximum change at that time. Okay, so we still use tissue Doppler in some extreme situation, but majority of what we use today is speckle tracking echo. Okay. The main problem with tissue Doppler imaging is it's angle dependent, and again, you know, it's difficult to get the ultrasound beam parallel to the moving structure. So we need a much better ultrasound tool to look at strain. So we came up with speckle tracking echo. So speckle tracking echo. So what is speckle tracking echo? So let's go back to physics. When we did physics, we talk about constructive interference and destructive interference. Again, constructive interference is like when a crest meets a crest or a trough meets a trough, you get a sort of additive effect. So the resultant is an increase. So in ultrasound terms, it's going to look brighter with constructive interference. With destructive interference is when a crest meets a trough or a trough meets a crest and it cancel out each other. So you're going to get a decrease in intensity of the ultrasound. And what that looks like, it looks like a darkened area. And that is why when you look at your regular ultrasound, you have varying shades of gray, or you'll have some bright, some dark, some bright, some dark. We call that the gray scale, okay? Because things looks gray, but if you look at it carefully, it is some black and some lighter, some black, some lighter, and that's because you're having constructive and destructive interference throughout the image, okay? So those little speckles, which is due to constructive or destructive interference, that's what we call the speckle, okay? That's what we call the speckle. And you can actually look at the movement of those speckles, and it gives you much more accurate information as you know to when you're looking at the function of the heart muscle. Okay, so again, when you look at your grayscale, you look at your echo, you're gonna have varying shades of gray. Some gonna be gray, some gonna be looking black, and you know, light gray, black, and that's because you have constructive and destructive interference throughout the the throughout the image, okay? And those speckles are not really angle dependent by and large. They're not angle dependent. So they're not angle dependent. So you can use them to assess your cardiac function plus other things. Okay? So that is what we call uh, those are the speckles due to constructive and destructive interference. And so using the speckle tracking echo, we can do strain analysis. So again, it's angle independent. We use the technique to evaluate myocardial function. And again, you see the speckles on the gray scale, B mode imaging. Okay. Random noise is filtered out, so you just get the varying shades of gray. So you can use your speckle tracking echo to look at the varying displacement information, such as velocity, strain, and strain rate. We're only interested in strain today. So again, it's an offline technique. So you're not gonna do the so this is 2D speckle tracking echo. So it's an offline technique. Okay, you're gonna use a low frame rate. Well, you don't want to use too much of a low frame rate. Okay, you want to do a frame rate between 40 and 80 frames per second. So not lower than 40. Okay, so within this range, 40 to 80 frames per second. With higher frame rates in patients with tachycardia, you probably want to use higher frame rates in patients with tachycardia, and you know, if the patient is very tachycardic, you might even want to use tissue Doppler imaging as your tool for doing strain. Okay, so again, you can use your 2D speckle tracking echo to look at your myocardial mechanics, the displacement, the velocity, the strain, and strain rate. We're only gonna, for clinical utility, we're just gonna concentrate on strain. It is not good to look at the right atrium or the right ventricle, and that's because these walls are fairly thin. So it's not good for looking at the right atrium and right ventricle. But almost all LV segments can be analyzed. Okay, so again, you're familiar with these image. So this is a this is your two chamber view, okay? And you have your inferior wall and the anterior wall, and you have the different segments. So all you do is you you choose what segment you want to look at. So you want to look at this. So this is going to be a basal anterior wall in red, and you speckle tracking echo. You put your sample volume right there, and then you get your strain curve. Okay. Remember, the peak strain should be about -25. Okay. So you get your peaks, you get your strain curve, and the peak strain is right down here. So you want to look at, say, the mid anterior wall. You do the same thing, and then you get the strain curve for that. You want to look at the apical anterior wall. You put your sample volume there, and it will give you the strain curve. And then for the inferior wall, basal, mid, and apical. So you can get a series of strain curves, and you can look at the curves, look at the contour of the curves, look at the peak strain, okay, to see if you have normal function, systolic function. Again, remember, this you're using speckle tracking echo, and you're following the speckles, and the speckles are due to constructive and destructive interference. So when they did the strain analysis using speckle tracking echo, and they if you look at the curve, you see that some of the curves are is not getting down to -20 something. This one is abnormal. So when they look at it, the abnormality was in this distribution, And this patient went on to have an MRI, and the MRI also showed that there is an infarct in the same distribution. So you can validate your speckle tracking echo because your magnetic resonant imaging, your MRI, which is extremely accurate in picking up myocardial infarction, sort of validate your speckle tracking echo. Okay, so but basically that's how it's done. We talk about longitudinal strain, the heart contracts from the base to the apex. We talk about radial strain, where it thickens, and then the circumferential strain, where everything goes inwards. Okay, so these are the different deformation curves. Okay, so this is your velocity curve. Okay, um, this is your displacement curve, and then this is your strain curve, and this is the strain rate curve. Okay, but the one you need to really know is the strain curve. Okay, and it's a longitudinal strain, so that is why it's below the baseline, because you have shortening. When the heart contracts from base to apex, it shortens. So these are negative numbers. So a series of negative numbers. So the curve is below the baseline. Okay. And this is your ECG down here. So we talk about systole. Okay. So or well, it's a complete cycle. So in systole, the base moves up towards the apex, and in peak systole, which is about the end of the T wave, then you have maximum shortening, and then in diastole, it sort of it lengthens, and that is why you're now getting less negative, because it's lengthening. So in diastole, it lengthens, so at the beginning of systole, it shortens, so it goes down, and it becomes very negative, and then it lengthens and becomes less negative. So this is the strain curve. Okay. So there are some potential pitfalls of your speckle tracking echo, even though we say it's the best thing since sliced bread. There are problems with 2D speckle tracking echo. What you really want is your 3D speckle tracking echo. But anyway, 2D speckle tracking echo. Uh, if you have a suboptimal study, then you're gonna get suboptimal tracking of the endocardial border. So you need to get a good study. Okay. Uh, you have a sensitivity to acoustic shadowing and reverberation. So therefore, with a poor study, you're not going to get a very good speckle tracking echo. Global strain may be inaccurate if you have too many segmental strain values that are discarded, because remember, you're going to discard some of the segmental strain if they're suboptimal. So if you discard too many of them, then it's not gonna, the global strain is not gonna be accurate. Um, Even though we say it's angle independent, it's not completely angle independent, because we have constructive and destructive interference. There's some amount of angle sensitivity there, but the important thing is you need good imaging. You need good quality imaging to use your 2D speckle tracking echo. Again, it relies on high temporal resolution. Uh, if the patient have a very high heart rate, tachycardia for whatever reason, then you probably should use your tissue Doppler imaging. And the reason why you don't have widespread use of strain is because the different vendors, the GE, the Philips, they have different protocols. The protocols are now being standardized, so that is, so you'll see more reporting because the results are standardized. Okay, three-dimensional speckle tracking echo, that's the way to go. It is more homogeneous spatial distribution of the measured parameters in the normal ventricle, so it's a much better uh, imaging modality, and you get very close agreement with MRI. It's fast and potentially more complete and more accurate analysis of myocardial function. So three-dimensional speckle tracking echo is the way to go. Okay, so we're gonna stop there, but speckle tracking echo is nothing more than when you look at your grayscale, when you look at your two-dimensional echo, you have varying shades of gray, so to speak, and that's because you have constructive and destructive interference. When you have constructive interference, you have brighter echoes. When you have destructive interference, you have darker echoes. So, and that's what you follow. You actually follow the movement of these speckles, and you can look at the different deformation of the heart in terms of displacement, strain rate, and velocity. All right. So on Thursday,